Welcome back. So, in this third and final lecture, we are focusing on the third learning objectives. Here, we're going to apply economic evaluation, apply it to health decision making. So, as I said, um, much earlier, we are going to use a couple of case studies to help drive home the point. So, but before we get to the case study, let's kind of give a little bit of overview. How about economic evaluation and health decision making. So this module is kind of relatively limited in the knowledge or in the aspects that we covered, in the sense that you may not be able to conduct a economic a data analysis for economic decisions, especially for those very complicated analysis like decision analysis or using any modeling approach based off on this module, but it does give you sufficient information that you can use to design a economic evaluation or interpret the design, quality, and relevance of an already published economic evaluation. So I tried as much as possible to cover as much areas as, that you might need in order to be able to look at any published economic evaluation, and you are able to have very educated conversations about it. So, but there are also other resources that you can use to improve your knowledge and to improve, increase your understanding of this topic. And an example would be the NHS Economic Evaluation Database. You can, I've included the link to it. You can go over to the database and just kind of have a sense of the information that is there. So the abstract that is in the database kind of coming into formats. You have the prospective evaluations that are typically a single study, and then you have the retrospective studies that usually include modeling, and these are done by, they have gone through a critical appraisal by experienced health economics. So they know what they're doing. So those are the two options that you can look into if you want to learn more about understanding and interpreting economic evaluation. So additional resources on the database is that for each of the studies on that database, there's inclusion of commentary by the Center of Reviews and Dissemination. So this, what that commentary does is to provide a structured overview of the quality of the paper, just in case you're feeling a little bit not very confident to be able to assess the quality of the paper. Go and read the commentary. It gives you a pretty good picture of the quality of the paper. So this is all the resources that you can use to further improve your knowledge on this subject. So let's talk about assessing the quality of economic evaluation. So let's say that instead of designing an economic evaluation, what you have been tasked to do is to assess the quality of already published economic evaluation studies, right? You're not doing the designing yourself. You're not conducting the studies yourself. You're just basically assessing the qualities of those, the ones that have already been done. So there are toolkits that have, been that are available to do this quality appraisal. These toolkits are validated instruments. They've been, they've gone through the validation to be sure that they are standardized and they are good quality, and they are able to objectively assess the quality of economic evaluation studies. So you have the Consolidated Health Economic Evaluation Reporting Standard, which is the CHEERS. I have included a link to it to kind of give you a paper to give you an idea of what that looks like. And then you have the Quality of Health Economic Studies, that's QHES. Also, this is another validated toolkit for appraising the quality of an economic evaluation study. There are a couple of others other than these two, so you can learn about them in this resource that I've included, just in case you want to know more of what those are and how are those toolkits used. So this is a snapshot of the CHAIRS toolkits and some of the information of what it is measuring. This is not everything. You can look at. I've included, the checklist on the additional resources on Canvas, so that you can go and see the full checklist in CHAIRS to kind of see what it is that you would use that to evaluate. So part of it is looking at on that title, they want to make sure that the authors have clearly identified the study as an economic evaluation and have specified the interventions as being compared, right? And then in methods that they have indicated whether it's an economic analysis plan that has been developed and where it's available. And then there are a couple of other things to do. So there is a way of scoring CHAIRS. That's how you do the appraisal. So you look at all of this information and you look at the studies and indicate whether those are there. So they have different scoring metrics for it, but I've not included that information here. But I just want to let you guys know that the CHAIRS checklist does have a scoring a way to it. And this is the QHES. Looks a little bit different from CHAIRS. As you can see, the scoring also happens in a different way. From CHAIRS is a shorter toolkit. It has fewer items on it. This is not everything. This is just a snapshot, just to let you guys see what that looks like. I have also included the checklist itself, the full thing in your additional resources, so you can go over and have a look at that. So some of the things that the QHES is measuring is whether the study objective was presented in a clear, specific, and measurable manner. It's also looking at, was incremental analysis performed between alternative for resources and cost. It's also looking, it's also looking at where primary outcome measures for the economic evaluation clearly stated, whether it was short-term, long-term, or negative outcomes included. So it really, really looks at this. They kind of are measuring different things. They're not exactly all looking to see the same thing. Meaning that some of the times the CHAIRS toolkit could tell you that a study is high quality, while the QESE will tell you it's not so quality. So I'm going to use an example of this. This is a study that I published. I was the first author in it. This was my first economic evaluation study. I did this as a student, a PhD student. That was when I, really said, this is what I want to do. I was very, very interested in it. What I did in this study was to compare the cost of implementing community-based interventions for HIV testing in sub-Saharan Africa. And I did this as a systematic review. So in this systematic review, I had about 10 economic evaluation studies that I used, and what I did with those appraisal toolkits was to, look at how high quality they were. So I used both CHAIRS and QHES for that. And as you can see, for some of this, there's discrepancy in the way CHAIRS is scoring some of the studies and the way the QHES is scoring some of the studies. For example, in this one, the QHES says is fair. CHAIRS, on the other hand, says is poor. So it's really kind of it's different. So this is the CHAIR score category. It has high, it has fair, it has poor, and it has extremely poor. And CHAIRS has high, average, and poor. So as you can see, it's not exactly the same. metrics that they use, but if you by using both of them, you kind of get a sense of what's going on there. So in case you're interested in reading the full paper, you can just click on this example and you will see how that systematic review was done. But this is just to give you an example of how you, in using two separate toolkits, can kind of get you having results that are, that look a bit different from one another. So you may want to use more than one toolkit to appraise the quality of an economic evaluation, to kind of get a bigger picture of what's happening with that. So now let's get into the case study proper. So with the first case study, we are looking at technical efficiency. And say in this case study, you work for a clinical facility, and this facility you work at, maybe they're facing some financial difficulties, or they just basically feel that they are hemorrhaging too much money, and they decide that they want to cut costs, right? And one of the things that they're doing in determining where to cut the cost is reviewing their clinical operations. And so one of the clinical operations that they're thinking of where they will cut costs would be treatment options for fungi toenails, right? And for the treatment options, they have 4 of it. You have drugs A, B, and C. And what the hospital administration of the facility is looking at is what is the cheapest option of these 4 treatment options. That's what they're interested in. Out of these 4, which one is the cheapest? Tell us which one is the cheapest, and this will keep the cheapest one, and then the rest of them we are going to stop putting money into it and stop providing those services, right? That's what your job is. Your job is to compare the 4 treatment options and come up with, say, okay, this is the one is the cheapest and this is the one you should go with, and then that will help them in making a decision based upon which treatment option to keep and which ones to drop. And so in order to do this economic evaluation to help in the decision making, you work with different people in the organization to collect data on some of the direct medical costs that is associated with these treatment options, but as a way to kind of standardize it, you are looking at it in terms of 100 patients for each of the 4 treatments. So that's how you want to look at it, in terms of 100 patients. How much was spent in treating 100 patients, and what did that come up to? And so this is the data that you collected from the organization, whoever looks at it. And then you have under your direct costs, you have drug acquisition, you have laboratory tests, you have treatment of side effects, but you also kind of put in some indirect costs. You have worker replacement, productivity loss. You kind of had some of those, so you kind of put in numbers for that to help you in deciding what would be the total cost for each treatment option, right? So this is the table that you come up based off on the data that you collected. So the type of economic evaluation you'll be doing for this case study is a cost minimization analysis. The reason is because you're going with the assumption, the premise in which it is that all of these 4 treatment options have the same benefits. Therefore, it doesn't really matter which of the options you go with, they have the same benefits. So you're not losing any benefit as a result of not choosing that treatment option. So that is why it's a cost minimization analysis. You have made the premise of which is that benefit A is equal to benefit B is equal to benefit C is equal to benefit D. This means that your evaluation or your calculation is only going to focus on cost. So now you'll be measuring the cost of A, cost of B, cost of C, and cost of D. You're using this to come up with a result that you would then use to inform administrators, this is, upper management, this is what I think you should go with. And based off on the data that you collected, you find that drug D has is the cheapest of the four at $1,255, while drug B is the most expensive in terms of total cost at $1,553. Therefore, this means that cost D has the cheapest option of the two, and therefore you then recommend to the management or to whoever makes doing all of the decision making that they should keep drug D and cut off the rest of them, that this is a way to save money. So this would be an example of using an economic evaluation towards decision making. So now let's go into the second case study, which once again is a technical efficiency evaluation. So in this second case study, you and your colleagues, you're designing a diabetes type 2 intervention program. And in order to implement this program, you have two choices of interventions that you can use. And part of what you need to do in order to implement the program is to request for funds, right? Either from, let's use, for example, NIH, or even if it's internal funding from, the budgeting office. But in order to request for funds, you kind of want to justify why resources should be allocated to one intervention versus the other intervention. Remember, you have two options of intervention, let's say intervention A and intervention B, and you are trying to justify why resources should be allocated to A or B, that sort of thing. So that's what your economic evaluation will be primarily focused on. And in order to carry out your economic evaluation, you decide that to measure your outcome, you're going to use incremental cost effectiveness ratio as the value for evaluating both possibilities, right? So you want to decide which of these two am I going to go with. In order to measure which of the two to go with, you decide you're going to evaluate them using incremental cost effectiveness ratio. I have included resources on this in case you want to know more about what that is and how it's used. Now, incremental cost effectiveness, sorry, I'm kind of jumping the gun. So part of doing an incremental, doing this incremental cost effectiveness analysis, calculating for incremental cost effectiveness ratio, is that you need a couple of information, right? You need information on the cost of implementing A. You need the information on the cost of implementing intervention B. You need the costs of, you need something to measure in terms of the effectiveness of A and B, and what you're using to measure the effectiveness is the number of patients who completed intervention A and maintained the weight after 1 year, right? That's what you're using to calculate your effectiveness, which in this case is your consequence or your outcome, right? That's what you're using to calculate that. And for the consequence of intervention B, or the outcome for intervention B, you are also using the same metrics, which is the number of patients that completed intervention B and maintain a healthy weight after 1 year. So this is the information that you need. So already you can see this is a bit different from the first case study, in which we have, assumed that the benefits they're all equal, right? They're the same. So in which case you only have to focus on focus on using the cost to do the calculation. With this case study, you have to calculate both the cost and the consequence in your evaluation. You're going to have to do both. So, and one of the things that you're going to be calculating is what is the difference in cost between the interventions. And to do that, you're kind of looking at cost A minus cost B. Same thing, what is the difference in outcomes between the interventions? outcome A minus outcome B. So this is some of the calculations you're going to have to do as part of your economic evaluation. And this is the data that you've collected of, let's say, from previous studies that have looked at implementing costs of those interventions. So you see that, okay, let's say the average cost of implementing intervention A is $79,000, and some of the reported effectiveness is that average of 78 patients maintained the healthy weight after 1 year. And for intervention B, you find out the average cost of implementing intervention B is $80,000, and in terms of effectiveness, it was an average of 80 patients that maintained healthy weight after 1 year. So the type of economic evaluation you're going to do for this case study, or you're doing for this case study, is a cost effectiveness analysis. Remember, in the first case study was a cost minimization analysis, the reason being that we were only looking at the cost. Now, this is a cost effectiveness analysis because what we are using to measure this is cost per unit effects, which is, how we do the cost effectiveness analysis, where in this case, the unit effect here is the number of patients who maintained weight after 1 year. So that's what we're using. So in order to calculate the incremental cost effectiveness ratio, what you're doing is cost A minus cost B divided by outcome A minus outcome B. So that's how the very simplified way of calculating a incremental cost effectiveness ratio. Of course, there are other complicated, more complex ways of doing that, but for the sake of our case study, this is a very simplified way of calculating your ICER. So in order to do that, after plugging in all of these numbers, $79,000, $80,000. So that's going to be 79,000 minus 80,000, and also divided by 78 minus 80. So that's what you plug in with your numbers, and then at the end of the day, you come up with the ICER being $500. So that's the result that came out of your calculation. In order to use this for decision making, you need to interpret this result, right? And what that means is that it is more cost effective to implement intervention A rather than intervention B. Now, let's use, for example, if the ICER you calculated was negative $500, what it then did, what it shows, or the interpretation of that result, is that it is more effective to implement intervention A rather than intervention B. So since we have $500 as our ICER, will be advising, in our grant application, we are going to say that we are going to implement intervention A instead of intervention B. So that's how that goes. So for the final case study, instead of technical efficiency, we're going to be looking at it from an allocative efficiency. So in this case study, you work at MIT as the research and advocacy officer for a department that serves as a policy think tank, right? And one of your deliverables for the year is that you are required to propose an alternative health policy reform, with your main task being to suggest the best cost reductive policy for it. So in order to come up with this best cost reductive policy, you decide, okay, there's actually 4 possible scenarios that you can use, 4 possible health policies that you can go to. Well, 4 scenarios, like 4 new health policies, but in addition to your remaining to the current one. So altogether you have 5 scenarios. So your first scenario is the existing health, the existing policy is fair. Nothing major is happening with the policy. we're kind of sticking to what we have. In the scenario B, it's a situation whereby there's going to be extreme reliance on free markets. Then in scenario C, there's going to be extreme industrialization. In this case, there's going to be strong move towards industrialization and corporate governance of healthcare. With your D scenario, you are working on the premise that there is a national economic crisis, and part of what happened during the economic crisis is that there was a major tax reform, and you kind of having, okay, what would that look like in terms of that, where it's going to lead to a major overhaul of government programs, which will also affect healthcare. So this is your scenario D. Then your final scenario is a proposal. This proposal came in 2005. I don't know how to pronounce the second one, but I know it's Emmanuel. I don't know how to pronounce the second one. My apologies. Anyway, so this proposal came in as a suggestion on how to achieve universal health coverage without there being a major overhaul of the existing healthcare policy, which in this case is before then, Affordable Care Act hasn't even come in, but it was one of those things that was floating around in terms of what can we possibly do. So in the proposal, it was offering a 10-component voucher plan for achieving healthcare coverage, and this voucher was going to basically focus on American citizens that were younger than 65 years old. So you have your 5 scenarios, right? And what you want to do is to suggest which is the one that has more or less like a cost reductive, which of these scenarios will have the most cost reductive, in terms of what's going to happen. However, unlike the first 2 case studies where we went down to the nitty gritty and started doing, we pulled up our calculators and started punching in numbers. For this thoughts case study, we kind of want to hold off on the calculation first and ask ourselves a question. If I do all of these calculations and I come to those who will finally put paper to pen about it, are they going to look at it and say, oh, this is wonderful, but no, thank you? Because with policy changes, there's so many things at play beyond just money. An example would be politics. Politics really, really comes into play when it comes to policy, health policy. An example would be what happened with ACA and all the things that, happen in terms of trying to get ACA passed and everything. So you can imagine that before we get to the calculating, the calculation portion of it and punching in the numbers, we kind of want to look at, this evaluation from a more macro level. Like, we need to sort some things out before we get to the calculation, the math part of it. So one of which is to look at what is likely, which of these policy scenarios is even likely, to be able to even get anybody interested. So you can use a number of metrics to measure the likelihood of it. An example would be removing provider incentive to overutilize, major changes to staff requirements, increasing wait periods, reducing cost of malpractice coverage, restraining treatment choices to the most effective and stuff. So you look at all of this different possibilities of what would happen in order to achieve these scenarios, and then you rank it in terms of whether it's likely to happen, whether it's not likely to happen, or you just don't have enough information to be able to predict the likelihood of it happening. So, and then you have your table that has all your policy scenarios, and then you put in N, Y, and stuff. So, of course, if you're dealing with a situation where there's too many unpredictability, too many things are unpredictable, you're kind of dealing with muddy waters, meaning you cannot clearly see what's going on underneath, and it's very difficult for you to decide, okay, this may be a safe one to go because you don't clearly see it, but you still have to consider what is likely and what is not likely. So this is just to kind of show you how the different ways that you can use economic evaluation for policy decision making. Like if you can see this one, scenario A, E is absolutely out of the way. D has a lot more of the likely than all the others, so you're very more likely to propose going with D than going with all the other scenarios. So this give you an example.